Well, Dr. Baker, thank you so much for joining us. Welcome everyone to one of our GSACEP webinars. We are so happy to have a recently retired Colonel Baker come give us a presentation discussing a bit about his own career in the military. And I formerly was at JBLM. We didn't cross paths quite yet, but I heard a lot about all of your effects of what you were doing out with, is it I Corps or First Corps? Because I hear both. I don't want to do the say the wrong thing. But everything that you were doing out at JBLM, and so I'm really excited to have you give this presentation from the recommendation of Dr. Aisha Hull. So go ahead, Dr. Baker. We're excited to have you.
All right, thank you. It is U.S. Army First Corps, for the record. Um, but that might depend on the commanding general officer and on his preferences, of course. So, hey, it's a real pleasure to be here. Thank you for the invitation. My name is Jay Baker, and I just retired last year from the U.S. Army after serving for 21 years. And I gave a version of this talk to the Madigan residents a couple of months ago, and apparently it was good enough that I got another invitation. So I really appreciate the opportunity, and I hope I share some things of value with everyone. Um, let's see here. All right. So this is kind of an outline of the talk that I've prepared today. I'm going to kind of use my experience and tell the story that I know the best, which is my own story, about how I evolved from a clinician and as I learned to save lives, and the steps that or rather the experiences that I had that enabled me to kind of grow the impact as my responsibility grew too. Ultimately to a position where as I'm retired, where with emerging technology, there's a tremendous opportunity to create systems that learn and have the opportunity to save even more lives and ultimately perhaps even achieve the goal that was established by the National Academies of Science, Emergency Science, Engineering, and Medicine about 10 years ago, that for zero preventable deaths. Um, so all of this, of course, begins first with learning to save the patient in front of us, and this begins with the knowledge set. It begins with the judgment that we develop through training as physicians, and if there are any other providers, well, it's the same kind of learning sequence. It's knowledge and experience equaling judgment. So my story begins. After my first year of medical school, and I had decided that I wanted to be a doctor, but I didn't really have a clear motivation besides that. I don't know why. I was like, well, I guess I'll go to medical school. And I was coming back after a hike in the San Gabriel Mountains over Los Angeles, and I ended up in a line of a in a back on a backed up highway behind a fatal motorcycle accident, and I've been thinking deeply about, kind of my motivation for being a doctor. I realized that, well, and decided that I wanted to learn how to save lives. And so I went back to the Great Stone Mother. This is Los Angeles County General Hospital. It was built in 1932, and no, that's not when I started my residency. Um, but we're still working in this hospital. It's subsequently been replaced. Um, and I became very interested in emergency medicine and began to, as I was lucky enough to continue my residency at LA County, I did a lot of my training at this location called C Booth. And C Booth has been spotlighted in a number of, multimedia, I guess, presentations. It was in the movie Code Black, or in the documentary Code Black. Um, It's also like a major inspiration for the current TV drama, The Pit. Mel Herbert, the primary medical advisor for that television show, was one of my attendings. Anyway, Seaworth was crowded, it was busy, it was noisy, it was loud. Man, it was really scary as a as a first year resident. But by the time my residency ended, I was running Sea Booth as a senior resident. And they used to call us two stars because there were two asterisks by our names. But it gave this like military, kind of, I don't know, ethos maybe, as we were called the two stars. So I was running this, the busiest ER in the nation. I'd gotten really good at, kind of the knowledge and the procedural skills and the judgment, to save to save the dying trauma patient, especially in front of me, but many others. Um, and my time of residency came to a conclusion, and I was activated um, to active duty. And I left my carefree life in Los Angeles and arrived at Fort Carson, Colorado, where I was now Captain Baker. And and the day before my first shift at the emergency room at Evans Army Community Hospital, my boss called me in. He said, "Jay, you've been reassigned, and you're now going to be the regimental surgeon for the 3rd Armored Cavalry." And I didn't know anything about the 3rd Armored Cavalry. When I had done my Army training in 1997, kind of between wars before 9/11, I golfed 35 days. And so, joining an organization of tanks, um, and Bradleys and Apaches was a brand new experience. And I didn't know anything about it, but I took it very seriously because I thought that war was probably a pretty serious thing. I also, kind of took a mantle of responsibility upon me. I thought that it was really important for me to learn my job. And well, and that's how I started. I learned too that it was so important to be able to to think beyond the individual patient and to build the systems, really. This was my first opportunity to work at a system level, as I was responsible then for 3rd ACR's trauma system. And in 2004, there was a new thing on the street. And I, spent some time online looking up how to be a good regimental surgeon. I found this thing called tactical combat casualty care that at the time was still very new. Special operations had been had experience with this. The Rangers were using this. This, of course, was invented by the Navy SEALs, but conventional forces had largely not adopted it yet. I recognized its value as an emergency physician. And I told my boss, H.R. McMaster, that we needed to train the regiment, that we needed to train all the troopers in the regiment. We needed to replace combat lifesaver, that at that time was IV fluids and STD checks, with hemorrhage control, with needle decompression, and with airway control as a third priority. And he agreed, and I went to the team and with my PAs and docs and the other medical leaders, we trained 5,000 troopers in 2 months before we went to Iraq. And I did my job there, and I learned a lot from that. And I learned that saving lives really depends on the systems built around the patient. And I learned that at regimental level, but there was something going on that was greater, that I didn't recognize until several years later. And that was that there was a system being built around the regiment and around all of the operational units that was going to be responsible for saving many more lives. And this was the Joint Theater Trauma System. So when we went to Iraq, there was no trauma system. And the Surgeon General of the Army had to get his combat casualty care data from the Washington Post. And for some reason, he thought that that was unsatisfactory. And so he sent this guy there in the middle photo, Dr. John Holcomb, to Iraq to assess what was needed. And Dr. Holcomb came back and said, well, we need a trauma system. We need to start collecting data. We need to analyze it. And then, and we need to communicate better so that like we can take better care of patients. And the Joint Theater Trauma System was born. And this is what it looked like in Iraq, in the early, kind of after the JTTS was established. It was not only a system of, I'll show it was a system that was led by a trauma director, assisted by trauma program managers, with support at the Role Threes. There were trauma nurse coordinators stationed at all of the Role Threes, and their core responsibility was to collect the trauma data at all the hospitals and to submit it to the Joint Theater Trauma Registry, and clinical practice guidelines started to be published. Even more important, or maybe equally important rather, is the concept of the JTS medical performance optimization. It was described as this operational cycle where trauma care is delivered, it's written into records. Those records are abstracted, or rather, basically, placed into tables, into Excel tables at the time, which were entered into the DoD Trauma Registry. Analysis shows from the registry what's working and what's not. What's working is published as clinical practice guidelines, and that's the performance improvement that improves the impact, that improves the quality of care on the battlefield. I'll talk more about this in subsequent slides. Um, but as I left Iraq and as I left 3rd ACR, I had opportunity to build additional domain expertise. And this, I think, is so important for for leaders, especially for medical leaders in the military, is to understand what's really going on. And it's greater than just what's happening again right in front of your face. It's greater than what's happening around you in the trauma room, even greater than what's happening um, in your deployed theater. But it's an expertise that can only be built through experience. And I started to build some experiences. I went to Seoul, Korea, where I was department director. I was responsible for the docs, the nurses and medics, and for the Korean ambulance drivers. I convinced my wife that a career in the Army probably wasn't such a bad idea if I could take her to Italy for real. And she agreed that I could sign another contract as my first contract was um, uh, finishing. So we went to Italy. The Army taught me how to jump out of airplanes, which is super fun. And with the 173rd, I then went to Afghanistan. In Afghanistan, I had an opportunity again, to focus on tactical combat casualty care, and had a kind of an interesting experience with the first casualty that we had. Um, he was hit by a roadside IED as he was walking, or a trailside IED, and he had a hole in his leg. And he was laying there bleeding, and the other soldiers were yelling for the medic to come running. Well, with their IFAKs, unopened on their waists, on the belts on their waist. So uh, we thought that an opportunity for improvement was to ensure that the infantrymen of the 173rd saw tactical combat casualty care as their responsibility. And so we made it the responsibility of the platoon sergeants, the infantry platoon sergeants, to lead the tactical combat casualty care retraining and sustainment training on a quarterly basis. Well, I came back from that opportunity, from that deployment, and I had an opportunity to come back and to build emergency physicians. As I was restationed to Madigan, and at Madigan Army Medical Center, I joined the residency program as an attending, and began to, and was assigned as director of the simulation program. I had an opportunity to really to understand what it takes, or rather, what good simulation teaching is composed of, about the back briefing, and the closed loop. Again, very similar to the JTS loop of teaching delivery, data collection, and analysis, and then performance improvement. Um, that system is everywhere as we look, and I'll show some more examples of that here, coming up. So while I was at Madigan, I had an opportunity to begin building teams beyond just the emergency physicians that I was training, and I deployed again to the Philippines as part of the critical care evacuation team, and had a nurse and medics that were working with me, and we had an opportunity then again to develop small unit team training to do a number of missions. And we worked also with the Philippine Special Operations, which was a lot of fun. I had a really great time on that deployment. Leaving there, So this is the kind of like there I was, this is what I did kind of stuff. But I'll get to maybe some deeper stuff here shortly. Um, and maybe here, beginning with the 528. So I joined the 528. This is the USASOC's surgical team. The sustainment brigade has logistics, intelligence, and a medical company. And they had the special operations resuscitation teams at the time. And when I joined, I was actually like pretty disappointed in the quality of the medical care that was being delivered by these teams. They spent a lot of time doing cool guy stuff. They were driving cars fast. They were shooting rifles. They were jumping out of, airplanes and helicopters. But the quality of their care was somewhat lacking. And so we implemented a bunch of changes. But I think that probably the most significant change that we implemented was that we placed these teams in a location, in a training location, where they had daily exposure to trauma. And maybe that was the reason why they, hadn't been performing at as high levels as they needed to. But we looked to the soft truths as we did this. And so these are the special operations truths um, that you see over there on the left. I looked all around the United States and finally decided on a civilian military partnership with Charlotte Medical Center or with the Carolinas Medical Center in Charlotte. And we stationed those teams there. Now, almost 10 years later, they're still stationed there, where they see trauma cases every day. The trauma surgeons, the emergency physicians, the CRNAs, and the special operations combat medics all take care of patients um, on a daily basis, the sickest trauma patients, to get the skills that they need to take to the battlefield. While I was there, I had an opportunity to really, kind of get into this austere resuscitative surgical care idea. The idea that small teams needed to have the skills um, and equipment, the skills and kit that they needed to be able to take care of the sickest soldiers on the battlefield. And got involved in this, really a kind of also a years long process to define the austere environment, to help write the clinical practice guideline, and then to write the JTS, or rather the joint learning objectives that establish a standard, the training standard for these small teams. In the Army, these are the FRSTs now, or FRSDs. In the Navy, it's the FRSSs. In the I think it used to be the ground surgical teams in the Air Force, but that might have changed by now. Um, so that was an exciting time, and something worthwhile to be involved with. While I left Fort Bragg and ended up in Stuttgart, Germany. In Stuttgart, I had the opportunity to continue to develop the idea of the small surgical team, but this time with through the frame of how to, prepare those teams to survive as part of irregular warfare. Now, this was in 2018 and 19, so this was before the Ukraine, before Russia invaded Ukraine. But I think it was pretty prescient. And some of our partners in NATO, the Lithuanians of the other Baltic nations, they were especially interested in these ideas, and had an opportunity then, you know, to help participate in this training and in your kind of the development of that knowledge set. After I left soccer, well, as I was preparing to leave soccer, I was interviewing for critical care fellowship, and I was offered an opportunity to, to really, kind of level up my system, participation, and I was offered a position in the joint trauma system. The joint trauma system, for anyone who doesn't know, is the DoD's or the DOW's Center of Excellence for Trauma Care. This is the system that followed the joint theater trauma system that had been established by Dr. Holcomb. As those wars kind of wound down in Iraq, Afghanistan, there was a lot of concern among the trauma community that the lessons learned from those previous from the previous decade would be lost. And so the joint trauma system was established. Um, it's now in San Antonio, Texas, and I had an opportunity, and they still manage and retain the DoD Trauma Registry. They're undergoing tremendous, modernization right now under Colonel Gurney, but it's an exciting time to be there. As I joined the Joint Trauma System, I learned a lot more about about the value of data. Whereas before I had primarily been interested in training improvements. I was very interested in the clinical practice guidelines, but I just had a kind of a more physical perception of the importance of trauma care. As I went to the JTS, I learned really of how important good data collection can be in transforming battlefield care. Now, this slide is a little bit busy. Maybe it's a little too busy. But what I'd like to share with the slide is the impact that the joint trauma system had on survival on the battlefield. So this line graph in the middle, you can see the years at the bottom on the x-axis show the years of conflict from OEF and OIF from 2001 to 2017 with survival percent on the left. And you can see that, or rather just kind of general percent on the left, you can see that as KIA and case fatality rate trended down over the course of the war, the survival rate of the most severely injured patients increased. And at the time that the study was published in 2019, Dr. Howard had estimated that the JTTS had achieved an estimated reduction of more than 40% in case fatality rate. He looked at the individual contributions of tourniquets, blood, and transport of, faster transportation times. You can see those on the right. Um, as individual contributors, and I asked him, well, what was the reason for the rest of the gains in survival? And he said, well, just like the general presence of the trauma system, and that reflecting, the many, the many activities and influences that trauma systems have in improving quality of care. So digging a little bit deeper, at some of the other data and some of the most impactful articles that have come out of the Joint Trauma System, the Golden Hour Policy um, report by Dr. Coatwell is very significant. So the Golden Hour Policy in way back in 2009, um, evacuations in Afghanistan were occurring at a much slower time than evacuations in Iraq. And the Joint Theater Trauma System leaders thought that that was a problem, and then they had the data to back it up, and they presented that data in terms of improved survival for faster transportation to Secretary Gates, who then published at least in the medical community, a famous memo that directed commanders in Afghanistan to achieve evacuations in less than 1 hour from time of call of the medevac request. And so, a lot of changes were made. It actually changed the number of it changed how aviation battalions operated. It changed where they were stationed. It caused additional rotary wing formations to be deployed into theater, and it constrained commanders to plan operations within golden hour rings. That became um, a famous term from the time. Dr. Cowell later looked at whether this made any difference, and you can see here that according to his analysis, there were an estimated 359 lives saved by faster evacuations. There's a number of other articles that I'd like to share now. Yeah, do I have a question or comment? Okay, maybe a hot mic. All right. So here, I'd like to just share in this slide a study that was published by Dr. Eastridge that, so we've learned now that, faster evacuation saves lives. Dr. Eastridge, in an earlier study, presented his analysis that more than 90% of potentially survivable deaths on the battlefield were due to hemorrhage, and that two-thirds of those were due to non-compressible injury in the abdomen or in the chest. So we know that the problems then are being defined here as time as evacuation time and as a bleeding problem. This is a study that was published by Dr. Shackelford. She was the JTS director at the time. She showed that pre-hospital blood transfusion was associated with lower mortality at a rate of 3 to 4 times lower mortality, and that and really underscoring the importance of early blood resuscitation in patient survival improvements. And then this is the kind of the last data study that I'll share, and this is also by Dr. Shackelford. She looked at handoff time to surgical teams, and she found that a shorter handoff time to surgical teams was associated also with a lower 24-hour mortality, approximately 3 times as well. It was interesting, though, that even with the earlier handoff, a faster time to surgery was not found to have an improved survival rate, suggesting that simply the handoff of severely injured casualties to skilled resuscitation teams might be that alone might have a significant impact as resuscitation occurred and as access to a surgical theater for surgical resuscitation was more readily available. So in my time at JTS, I really again got into the data. I did a number of other things there, including supporting the combat the combatant command trauma system when Russia invaded Ukraine. And as Russia invaded Ukraine, well, we knew that the world changed. And as the frame that we had been using for the last 15 or 20 years of combat casualty care, of planning, with small teams to take care of small numbers of casualties, we knew that a significant a shift was occurring. And that the new problem was, to build a system to save thousands, and not just dozens or scores. So as I left JTS, Colonel Gurney, the JTS chief, recommended that I read this book called The Kill Chain. And this is a book by Christian Brose where he describes the the impact of AI on the targeting chain and on shortening the acquisition. The kill chain then describes um, the time from target identification to target elimination, and how AI and machine learning has a potential and really the true capability to shorten those times through quicker data analysis and decision making. And I thought that, well, there must be a way that we can do this to save lives too. So as I left for my last assignment with U.S. Army First Corps, my first experience with First Corps was a large-scale exercise in Hawaii, um, called Talisman Saber. And in this exercise, there were, I think we had like 15 or 16 nations. The scenario was a large aggressor in the Indo-Pacific who was invading island nations, and and our task was to push that invader, back out into the waters from where they came. And there was a joint forcible entry operation that we were planning for. And as we were planning for this, um, I found that the medical planning, although we had a plan, didn't have any way to estimate if our plan was adequate. We had no way of estimating if I had the right number of surgeons, if I had the right, number of units of blood, if I had the right class 8, if I had the right hospital beds or evacuation resources. And I thought that it'd be really helpful if someone designed that kind of system that was able to estimate those the resources that are needed. Now, I will acknowledge that there is there is a resource that does this. It's called the Joint Medical Planners Tool, and it has the Medical Planners Tool Kit as the casualty estimate tool. And there's some issues with that. The issues are primarily that it's a very static system, and it's hard to, well, it's really kind of hard to use. I did the training, and I don't, I'm not hating on JMPT, but I needed a tool that was as fast as for planning as military operations occur. And I went back to my staff then, and we sketched out this concept of how the battlefield trauma system should operate in our minds. And this shows evacuation of casualties across an army, really across army formations, um, that differ for different triage categories of patients. If you look at the top line that shows the severe surgical patients, you can see that in this concept, the most severely injured patients are going to go to the closest, highest capability on the battlefield, while the patients that are less severely injured and can tolerate a longer period of evacuation will drive right by those higher capabilities that are closer to them, not clogging up those resources and being delivered to the care that they need at a location that's further back on the battlefield. The joint trauma system has a slogan that goes something like the joint patient, I'm sorry, the right patient to the right care at the right place at the right time. And this battlefield trauma system captures that, and it also underscores the opposite, which I think at scale is equally important. And that's that you don't take the wrong patient to the wrong place for the wrong care at the wrong time. So after retiring from the Army last fall, I had the opportunity, I was invited to participate in Palantir's American Tech Fellowship. Palantir is a tech company that has created new technology that is enabled by AI and machine learning to do the kinds of things that the battlefield trauma system imagines. Um, I spent time again at this fellowship learning about its capabilities and have subsequently joined the Joint Trauma System, where I've been and I get to participate in the next level design and implementation with the Joint Trauma System as it takes its experience, it takes its deep knowledge and its deep data sets, and it pushes these through a program that you see here. And this is there's a lot on this slide. I acknowledge that, but it takes the data sources, it puts them through an ontology, and it's that middle section there where all the different data, the disparate data sources communicate with each other and are able to be presented in applications that are helpful for those users. Those users that are most helped by these are the medical providers, the medical commanders, and the commanders of our operational units. So I'm kind of coming up on the final slides here. The trauma system then, in that triangle that I showed previously, with trauma care delivery at the top, the DoD trauma registry on the right leg, and then with performance improvements on the left, is represented in this circle at the top with the medical performance optimization cycle. This is anchored, of course, to the trauma care that's delivered to the patient. There are many other cycles that are important in caring for trauma patients at scale. And I've represented a few of these on this image here with Class 8 evacuation, with the training that medical providers and others need, with the medical units that are supporting care on the battlefield, and finally the planning and operations that ensure that we have the right units in the right places, that they have the right Class 8 that they are able to provide the right evacuation to take the right patient for the right care to the right personnel who have the right training to deliver the right care at the right time. And this is, as we move into the 20th century, 21st century, as we move from the 20th, deep into the 21st century, um, this is a really exciting time to be in the Army now, especially as you're just starting your career. This generation, your generation, has the opportunity and responsibility, to build those systems that are modeled after the JTS and that integrate with the Joint Trauma System to save even more lives and to, get closer and closer to that target of zero preventable deaths. And so I'll just go ahead and this is my final slide. And I'll offer this as a challenge and a question. And I'm welcome to take any questions as I ask, what will you build?
Jay, I have a question for you. This is Colonel Hall, and that was an amazing talk. And I'm just wondering, I'm going to ask you like a question that you can't really answer, but um, like, how do you see AI working into this? Because there's a lot of hype right now about some of these systems out on the battlefield. I live obviously in the point of care ultrasound world, but there's some systems out that they're like hoping that medics will be able to use to tell if there's free fluid in the abdomen. And, so that's the AI that I'm familiar with. But what other kind of AI things are you aware of that are kind of being looked at by the trauma service, and what impact do you think that'll have?
Yeah, thanks, Aisha. I appreciate that question. So, yeah, so AI is absolutely going to impact and change the way that we are able to provide care, and it's going to do so by by multiplying the speed of data movement and interpretation across, well, at every level, and in every domain. So, the example that you gave about, medics being able to identify free fluid in the blood, in free fluid in a body cavity, is, the function of AI to do that is to multiply the speed of interpretation and to build in rules for interpreting and providing then, direction to the medic. This occurs like across every level. So uh, I'm thinking about which, so as I'll go back to this battlefield trauma system diagram, with AI at every level. AI will enable the triage, and identification of what patients need. The example you gave was a patient who needs an XLAP, an exploratory laparotomy. With additional sensors that feed data into AI algorithms, they'll be able to identify which of these patients need surgery the fastest, and that will help determine um, which evacuation platform that medic needs to, or that patient needs to be placed on. It will enable the communication, and faster and more complete communication with the receiving units. It will enable units that are full of patients to be able not, to send a signal that for diversion, to other facilities that are more prepared and better ready. So, AI it's a information. Um, it speeds up the flow of information, like remarkably, 100x, 1,000x sometimes. Um, and it's in this system too that the joint trauma system is going to be able to, well, is building now tools that will, that are AI and that are enabled with AI to, bring together, these disparate, kind of and related but disparate data points of that you can see here across this column of objects. The AI will enable these actions, which will then again, enable the functions that I described earlier on this tactical battlefield.
Thank you. I knew that was like a big question because AI is a big topic, but it comes up frequently. And again, I'm kind of pigeonholed in the POCUS world, but um, I really appreciate that.
Hey, Colonel Baker, can you hear me?
Yes, Mason.
Sir, great presentation as always. I appreciate you kind of going through your thought process from beginning as an intern, kind of going through as a battalion surgeon all the way up to the first corps. Are you able to talk a little bit where you see the role of autonomous systems kind of playing their part in artificial intelligence and machine learning for the trauma system?
I sure. I'll give you my best stab at that. I think that autonomous systems, you know, we haven't started working on autonomous systems that I know of at the Joint Trauma System. DARPA is probably doing some stuff about that, currently. I think that autonomous systems, um, are going to, well, actually, let me ask back to you, Mason, what do you mean by autonomous systems?
In talking with you in the past about how we can have real-time feedback and offloading our medics, our surgical teams with um, autonomous, whether that's IV fluids, things where I, as the surgeon, can be offloaded by a robotic capability or something that helps us, you know, increase our capabilities of care while offloading the personal, intelligence aspect of it with autonomous systems. And then how can we use that to leverage this feedback mechanism of MPO to then increase our care capabilities, whether that's point of injury, surgical, or back here at Walter
Okay.
Reed and Roll 4.
Yeah. Okay. Okay. I understand a little bit better now. And yeah, so I think that I agents, and the kind of the work that is being done with agents, and the explosion of agents right now, might be the first step towards what you're talking about. So when I work emergency medicine shifts, um, I would really love a robot to write my note. And to like so I would like an agent. This doesn't like this might exist in a different in a better information system than Cerner delivers to the military, certainly. Or this, Cerner instance that I use. But I would love an agent to sit within my chart to, take the, to take my dictation. Well, really, and this begins even with like ambient dictation. To take that the historical information that's collected on the patient, and then to integrate that with the lab information, with the radiologic with the radiology information, with and with maybe with my consultant's advice, and then to write my note for me so that all I have to do is review it. Um, and approve it, And so I think that, and if my agent note writer did that autonomously, that would make my life a little bit better. I think that, and so, kind of expanding up from the individual patient level and provider level, um, I think that, building agents, that overlook, whole systems of of medical care, that look at, the different roles, that the different units arrayed across the battlefield, that they're able to use the data that and reporting that's coming in from those, and it then is able to direct, um, resupply, both in blood as and other Class 8. It's able to direct um, evacuations, orders. It's able to, direct, um, air evacuation requests, so patient movement requests, kind of, and it's able to produce the information that then a lot of this still needs humans in the loop for the judgment. I don't know that judgment is ever going to be taken out of medicine. I kind of doubt it. But I think that, the autonomous, information, kind of collection and interpretation will can is coming, and it's coming very fast. And so that's where I think we're going with that. Now, in terms of us giving robots decision-making capability to, launch their own evacuation missions or to, transfuse blood, for example, that's a little farther away. Um, I don't know that AI has proven that it's able to judge well in critical situations.
Thanks, sir.
Thank you for the question, Mason. All right. Well, I'll just make a couple of additional comments. I retired again from the Army last year. I'm working now as a consultant with the JTS. And some of the things that we're working on are, described, are what I'm showing here kind of in this slide. And, if you haven't seen something like this, you don't have a exposure um, to kind of this problem set, it's maybe a little difficult to understand, but we're building this layer now, the JTS layer exists already, or rather the architecture, that moves data, from sources, through interpretation, into a place where, we're able to, link this to CPGs, and we're able to, and we're able to provide, commanders' theater reports, and dashboards. We're currently working on helping the Defense Logistics Agency build a similar architecture that's going to come together in this ontology. And, ultimately at the strategic level will be useful, for example, estimating what the medical resources might be needed for if large scale conflict occurred in, oh, I don't know, let's just say Southcom. Like what if we went to, what if we had a contingency, of a specific size, based on O plans and op orders? These ontology layers then that are connected as we connect with the JTS, kind of patient information with the Defense Logistics Agency's, Class 8 information. And we estimate then, based on the casualty estimates, what those supplies are. That's going to help combatant commands, as well as, that's going to help combatant commands estimate what is the class 8 that they need to support that contingency. And then, that information can be, kind of pushed back into DLA for contracting with defense, or with medical manufacturers. And as political conditions in the world, might evolve in different directions, there may be plans written to launch, I guess, medical manufacturing to support those different contingencies based on, how political situation is developing in the world. So that's maybe pretty high level perspective, but this is the kind of work that's happening, and that I have a tremendous opportunity to be part of right now. We just need to bring this down to the tactical level. So questions like Aisha's and Mason, like yours, can get more satisfactory answers, I think. But that will happen in time. And I think that, again, that is what I'd ask you guys. What is it that you want to build? Especially as Codex, and Cloud Code and the other AI-enabled coding systems allow non-programmers like you and me, because I'm not a programmer, to participate and to build solutions to the problems that we see in front of us. And so I'll go ahead and end. Thank you guys very much for calling in. And thanks to Aisha for recommending me to share this talk with GSACEP. I hope for GSACEP that it was well received, and I look forward to the next time.
Thank you so much for your talk, sir. I truly appreciate you taking the time in your busy schedule to chat with us and share your experiences, and we will all, get better from hearing everyone's experience. So thank you so much.
All right. Thank you all.
And thank you everyone who logged on. If you didn't catch the whole thing, we should have it recorded and put it on our website, as long as Dr. Baker's okay with that. And then we will be happy to share as well.
All right. Thank you.